So this is a 52-year-old male with a history of pancreatic cancer, and this is a CT specimen. So again, we are getting more and more of these pancreatic cancer specimens, so we have a little bit more experience to identify these very scattered, like small but tight cluster. And when you see the cluster, the first impression that it is a three-dimensional arrangement, so you need to focus up and down to see. And in the cytoplasm, it is very often that you can see some vacuole. So the vacuole appear to be like abundant, and it push the nuclear into a very angulated shape. So this is not a normal cell. This is malignant cell. Only the malignant cell can be present like this. Occasionally, we will see some mucin in the cytoplasm as well. Different labs have different staining pattern. In our lab, we turn to stain mucin more in an orogenophilic pattern. So again, this is a very tight cluster. Here is a vacuolated cytoplasm. Here is a little bit mucin over here. Usually these type of cell have quite small nucleus comparing to the other adenocarcinoma that we often see, such as coming from the lung or from the breast. So here is a very tight cluster. Again, you can see a little bit of mucin in these cytoplasm and arranged in a tubular or luminal pattern. So this is positive for pancreas cancer. So next, it's a patient of lung cancer. This is coming from the pleural effusion. So for the lung cancer, it is somehow more easy because usually you will see very large nucleus with a prominent nucleoli. And on low power, you can see scattered cell ball. So the cell ball is also demonstrate these three-dimensional architecture. And comparing to the adjacent histiocyte or mesothelial cell, these cells show enlarged nucleus. The chromatin pattern is more irregular with a vesicular pattern, and the most prominent feature is this cherry red prominent nucleoli. So this is positive, and the patient already has been treated, so this is compatible with recurrence. So the next specimen, also lung cancer. The patient has also been recently treated. So in this pleural effusion specimen, you see a lot of necrosis. This is most consistent with the tumor necrosis because of the targeted therapy. So you can see only scattered viable cells. Again, in three-dimensional architecture, more vacuolated in the cytoplasm, suggesting they have some degeneration, probably due to the therapy. In the background, there's massive necrosis. So this is compatible with metastatic adenocarcinoma, and the patient just recently received the treatment. So this is compatible with treatment response. So the next specimen is from a 72-year-old female. She had a past history of hepatocellular carcinoma. So hepatoma is usually, it's very, very rare that we can see in metastasize to the peritoneal cavity. It's only happen when it rupture. But when it rupture, the patient has in a very critical condition. So at that status, usually we won't receive any specimen because usually the patient already has been diagnosed. And nowadays, the treatment for hepatoma muchly improved, so it can be treated either with surgery, with embolization, and sometimes quite effective. In this specimen, we find very scattered, tight cluster with three-dimensional arrangement. The cytoplasm is quite plenty. It does not show this dense granular feature that we used to see in the hepatoma. So the overall arrangement, it looks more like to be an adenocarcinoma instead of a hepatocellular carcinoma. So again, we see a tight cluster arranged in a tubular or glandular pattern. So it looks more like a adenocarcinoma. It is very common that we receive patient might have 2 or 3 different kind of cancer. So in this scenario, you need to think about it is elder female, 72-year-old. So you need to think about that. Could it be a primary peritoneal serous or ovarian serous carcinoma? So in the cell block, we do have very, very scattered tumor cell. So we would do the MARK31 and PAXA to confirm that it is actually a new cancer, a metastatic adenocarcinoma instead of hepatocellular carcinoma. So cytomorphology do matter. In addition to the history, you need to think about the other possible scenario. So let's move to the fine needle aspiration. So this is aspiration from breast. And clinician aspirate a cystic lesion, and we receive a liquid specimen with 7.5 millimeter bloody liquid. So we perform cytospin preparation. So in this preparation, you see in the background, there are quite some like a granular, perhaps necrotic background. And we start to see scattered viable cells. And the cell can arrange in a like a very cohesive fragment, and the nuclear polymorphism is quite apparent. However, you can see very, very scattered myoepithelial cell within the same cluster. But again, you can see mitosis here as well. So overall, the lesion looks like that there is a neoplastic component. However, they were very, very scattered, like myoepithelial components still within this fragment. So it looks like a carcinoma, but it can be either, I would say, either in situ carcinoma, ductal carcinoma in situ, or it is papillary lesion still remain papillary carcinoma. There were various types, but there's a type and still remain some myoepithelial cell. There is a concurrent biopsy, I think it's by Dr. Shi. Kunping's here? No. So we can wait for the biopsy to decide what we report. I think it is okay to report it as positive carcinoma, but we might need to address there's a possibility that's in situ, not entirely invasive. So there are 2 Ascus pap smear. first one, there's only these focus. So the cells are mostly superficial, mature, keratinized cells. In these focus, they are quite some like enlarged nucleus, some with binucleation with a little bit strange shape. So I think it is better that we call this ASCA instead of just consider it is a reactive process. So some enlarged nuclear, because it's superficial cell, the cell is actually quite big, and some shows binucleation and some with these irregular contour. And the whole slide is not very well preserved, so I think it's better that we call these ASCAs. The second specimen, it is not very cellular. There were a couple of dots. The dot over here, although you see there are some orogenophilic staining, this is most likely a phagocytosis cell, degenerative cell. So these most possibly are coming from the endometrium. So there were very scattered endometrium component. So this one looks like it's the cell membrane is not very apparent. It can be a naked nuclear. So if it is a naked nuclear, we don't make interpretation on that. But these seems to be a little bit different. These show hyperchromasia. These are intermediate squamous cell with binucleation and hyperchromasia. The chromatin pattern is a little bit smashed, but still you can see some granularity. So overall, I think it is reasonable that we call these ASCAs. The whole background seems to be atrophied. So occasionally you can see something like this in atrophic background, but if it's just too much, we might use the ASCAs category for this scenario. Okay, so this is for today. Thank you. 真的。你是怎么跟他联络啊？
等一下有一个 case 那个临床